This conference is being recorded.
Yeah, okay. As you have heard, this conference is being recorded, so you can also listen to the presentation in the next days. And you can have more information about the Aging with HIV project on our website, agingwithhiv.com, or on our Facebook page, just searching for Aging with HIV on the Facebook. So let's start with our webinar today. We have, as you know, this is our first webinar in this project, and we have three very good presenters. We start with Giovanni Guaraldi from Modena, University of Modena. He's the chair of Clinica Metabolica in Modena, which is a very important center in Italy for addressing all the issues related to HIV. He's an assistant professor of infectious diseases in Modena and Reggio Emilia. Then we will have Alan Winston from the St. Mary Hospital in London, and then our community speaker, Mario Cascio from Italy. He is also an EATG member. But I will introduce each of them before the presentation. I will ask the speakers to speak for 15 minutes so we can have some questions after their talk and maybe some discussion at the end of the three presentations. For all you who are attending this meeting, you have been, your line has been muted now by our operator. So if you have any question, you can either type in your question in the chat. If you go with your mouse on the left side of your screen, a tab should appear with the participant tools, and there you can select the icon for the chat. And you can also see another icon with a speaker and an X. You can mute and unmute your audio line by clicking on that icon. But please keep your line muted during the presentation so to avoid any disturbing noise during the presentation. I think that is all, I hope so, that I had to say. So we can start with our first presentation from Giovanni Guaraldi. As I told you, his primary research interest is lipodystrophy and cardiometabolic complications in patients with HIV infection. He has been leading the metabolic clinic in Modena, a very important center with more than 3,000 HIV patients monitored there for HIV-associated chronic diseases. He has a multidisciplinary team caring for these patients at his clinic. It is a very important experience. He is also the physician in charge of HIV solid organ transplant center in Modena, where 20 HIV patients received liver or kidney transplants so far, and is a panel member of EATG guidelines on the prevention and management of metabolic diseases in HIV. So Giovanni, please go ahead. Thank you.
Good morning, good afternoon, everybody. And Giulio, thank you for your kind introduction. And so actually I was asked to give my clinical experience about the management of aging with HIV inside my clinic. And so I titled my presentation that is HIV is beyond undetectable, somehow to say that all what we're saying, it refers to HIV people who, thanks to antiretroviral drugs, are able to live with HIV and will get old with HIV. And so in our first slides, actually, I'll show you that actually there should have been an animation. It's not present. Can you give me first slide? Okay, actually to show that actually in my experience in the past 10 years, we've seen a really big shift in the pyramid of age of people attending my center. And so in 2006, the median age of HIV people attending my center was 40 years, and last year it was 51 years. And so actually it's quite apparent that most of people with HIV and people belonging to our HIV cohort are aging with HIV, but also you can notice that there's also a good increase of age at HIV diagnosis. That is, there are also people that are getting HIV at an older age, and I will try to tell you to what extent this means from a clinical perspective. Go ahead, please. And so you can see on the top of the timeline that is our let us say, clinical experience. The metabolic clinic started in the year 2000. That was the big problem at that time was lipodystrophy, and we were so much concerned about drug toxicity. It was, of course, a good successor of heart at that time, but we realized that there was a price to pay, and this was drug toxicity. Very soon after, we realized that this was not just an issue of toxicity, but also an issue related to, let us say, the aging of the population and the fact that HIV per se may play a role in the risk of comorbidities. But also, we realized that these comorbidities were associating in the same individual inside a multimorbidity pictures. In the bottom of this slide, you see two papers. The one was generated by our group, in which we highlighted the fact that at any age group, people with HIV had multiple comorbidities at the same time, and this work was somehow recently confirmed by Age HIV Court, which is a very important aging court in the Netherlands. Somehow to say that the prevalence of multimorbidity may be up to 40% in people beyond the age of 50. Go ahead, please. But what is interesting is that we have a very nice projection of what will be the burden of aging and the burden of comorbidity associated with aging in the next 20 years, because actually we have this important paper that is generated by the Athena Court, that is an HIV court in Amsterdam, in which we can see here that using the projection of the life estimation, we see that by the year 2030, up to 73% of HIV people belonging to the court will be above the age of 50. And this will translate in a significant increase of comorbidities, especially cardiovascular disease, you see in the bottom part, but also of multimorbidity. The next slide actually shows that if you still compare, next slide please, you still compare HIV infected and uninfected above the age of 50, you see that all at any age group, HIV-infected people may have a higher burden of multimorbidity compared to HIV uninfected, and this will translate in the need to treat these comorbidities into a polypharmacy approach. And so in the right panel, you see which are the burden of the co-medication that need to be used together with antiretroviral, and you see the yellow boxes tells us that the most commonly prescribed medication together with antiretroviral should be cardiovascular medication, essentially primary or secondary prevention for cardiovascular disease again. Next slide. I told you that the actual cohort, but also the future cohort of people living with HIV will be made up of people who survived the pre-heart and the early heart, that is, people that are aging with HIV, that is, they are getting old while being HIV people, but there is also an increasing number of people who acquired HIV at an older age. And you can see in this graph that comparing, in this histogram, that comparing to HIV negative individual, that is the yellow box, people aging with HIV will have a 5-time higher risk of multimorbidity rather than HIV negative individual above the age of 40. But people that get HIV at an older age will still have a higher risk compared to HIV negative, but somehow in the middle compared to people aging with HIV. What does this slide mean? It means that it's not that easy to say which will be the clinical characteristics of people living with HIV at an older age, because actually inside this population you may display quite a big difference in risk associated with living with HIV and comorbidities. Next slide, please. And so how to describe the fact that apparently two people of the same age, two people with the same comorbidities, you can see these two pictures, two 83-year-old people, both having hypertension, hyperlipidemia, and previous myocardial infarction, may have a totally different phenotype. how can we describe this issue, which definitely goes beyond the chronological age of these individuals, but also go beyond the presence of comorbidities of these individuals. And so this, let us say, variable vulnerability among people of the same chronological age is called frailty. Next slide. This paper is a consensus in which we have, let us say, a definition of frailty, but is also a call to action. And so we define frailty as a medical syndrome with multiple causes and contributors that is characterized by diminished strength, endurance, and reduced physiological function that increase an individual vulnerability for developing increasing dependency and death. And so what is written here is that frailty is a measure that tells me the vulnerability of an individual and is able somehow to forecast the risk of dependency and, of course, the risk of death independent by the chronological age of an individual. Next slide. And so the issue is how can I measure frailty? And you can see that there will be actually two different ways to measure frailty. The first approach is the so-called frailty-related phenotype. Actually, it was developed, let us say, in the almost 15 years ago by Linda Fried, in which she was able to depict 5 items that you should look at to identify a person with different, let us say, risk of developing dependency. This is weakness that can be measured with, let us say, a grip strength or a chair stand. Weight loss that actually tells me that there's a risk of sarcopenia or sarcopenic obesity, that is the phenotype, the anthropometric phenotype typical of older people. Exhaustion that tells me that actually there's a less increased oxygen expenditure for doing a certain work. Slowness, that is difficulty and slow walking time, and low level of activity that most of the time can be measured with accelerometer or with questionnaire. And so frailty is defined as a condition in which 3 out of these 5 items are considered pathological, or pre-frailty is if 1 out of 5 or 2 out of 5 of this condition is considered abnormal. Next slide. You can see in this work that was one of the first that was made in the Max Court. You remember the Max Court is the large gay men court, both with HIV and without HIV in US. You see that above the age of 50, at any age, HIV people appear to be frailer, actually 2 times frailer than what is expected in the general HIV negative population with the same age group. Next slide. This paper somehow has been recently been reproduced in Europe. It's very important to have, let us say, local data. This paper has been published a couple of weeks ago. Again, is from Peter Rice's court called the Age HIV Court. It compared 521 HIV infected and 513 HIV uninfected individuals that were recruited from a sexually transmitted disease clinic in Amsterdam. Next slide. You can see in the left bottom part that the prevalence of frailty criteria is always higher in HIV-positive individuals compared with HIV-negative, and this ends up to a higher prevalence of frail and pre-frail individuals in the top left part in HIV cohort. And if you see the multivariable analysis, HIV was an independent predictor of being frail, and actually this increased significantly the risk up to 65% increased risk of frailty just because of HIV. And actually this let us say, the second higher risk after the depressive symptoms. And so once again here you can stress the fact that not just HIV but also depression is one of the major determinants for risk of frailty. Next slide. Well, there's another way in which we can describe frailty. This other way is called the frailty index. And actually it says that, well, we can use, rather than, let us say, a qualitative approach, we can use a quantitative approach that is an index, a number. And this number just counts the number of deficit you have upon a series of variables, generally at least 30 variables that are routinely collected in clinical practice. And this may refer to cognition, to mobility, to social health, to comorbidities, to co-medication and health attitude. And so you see why all this issue, because actually these are the domains that are generally collected in the so-called comprehensive geriatric assessment that is the standard of care in clinical assessment of aging people. Next slide. This is a paper that we recently published from HIV Metabolic Clinic. We were able to build our own frailty index just using variables that we routinely collected at that time. This is a retrospective analysis. We didn't collect this variable because of the frailty research. These were just variables that we were used to collect. And we tried to see to what extent this frailty index was predictive of mortality, you can see in the left part, on the risk of multimorbidity, that is having at least 3 different comorbidities in the same individual. And what is nice is to see that frailty is totally independent by age to predict both mortality and multimorbidity onset. And so this somehow tells me that frailty is something that we can have already inside our database as soon as we have, for instance, an electronic database that allow us to collect some health-related variables. Next slide. And so just to give you, let us say, why we needed to screen for frailty, this is the same car, but of course it's a car that was produced in the same age, but you can see that there's a big difference. And so I needed to distinguish what is the difference between biological age and chronological age. That's why I need to have a frailty measure. Next slide. So this is the reason why there are some interesting programs across different health systems. This is the case of France, in which actually it's asked from GPs to screen for frailty in the population. And you can see these are very simple questions that any GP should collect so that to refer to multidisciplinary clinic and offer, let us say, an integrated approach so that to collect information of people that are getting older with, let us say, a higher risk. Next slide. Why is needed to screen? Because actually if you recognize frailty, you can do something to avoid that frailty is associated with, let us say, with health risk. This is the first paper that was published in 2014 on JAMA that actually showed that, let us say, intensive physical activity may reduce the risk associated to frailty and reduce the risk of mortality and morbidity. This is to say, we should screen frailty in any population, especially in population like HIV people that are at higher risk for frailty, because we can develop interventions so that to reduce the health outcome. So I will stop here because actually my time is over. I'm open for discussion, and I think that is interesting to understand to what extent we may introduce frailty measure inside our clinical activity and try to, let us say, add a frailty measure to the measurement of comorbidities and multimorbidities as a possible outcome for clinical evaluation, and maybe in the future for clinical trial that may be also informative how to choose antiretroviral and HIV-specific issue in people living with HIV. Thank you.
Thank you very much, Giovanni. Very interesting presentation. I think we have already some very interesting questions arising. So let me remind all the participants how to ask questions. You can either type in your question in the chat. You can find the chat if you move your mouse on the left side of your screen, or unmute your line and ask your question. But we have a first question now. Is lipodystrophy still a significant issue for the older people living with HIV now, and how it is related to the aging process? any suggestion for the management of this clinical problem? I mean, this is a very interesting question because we have been associating aging with lipodystrophy in the past years very often. So is it still the case, and how we can manage that?
So I think this is a very interesting question because actually there's a lot of research that still need to be done. And so first of all, you know that there has been a very important study in, let us say, in the past that is called the FRAM2 study, and this study was able to tell us that lipodystrophy is not one disease. It's at least two different diseases. One disease is lipoatrophy, the second disease is lipohypertrophy. Okay. With regard to lipoatrophy, we got information on the pathogenesis that was mainly driven by antiretroviral toxicity, especially thymidine analog drugs were producing this kind of lipoatrophy, and we are all aware of the fact that this disease is somehow less prevalent and is no more the case with regard of the antiretroviral drugs we use in the current time. You may also be aware that EMA just in November produced, let us say, a document to say, well, the current antiretroviral drugs are no more at risk of developing lipoatrophy. This is not the issue with regard of lipohypertrophy. At that time, we defined lipohypertrophy as an increase in fat in the visceral adipose tissue, in the liver, in the epicardial adipose tissue, and so any, let us say, kind of ectopic central fat. Okay. So far, we have no proven data that this is a drug-related condition, but actually appears definitely to be the same phenotype that we experience in older people. What we know is that the general population above the age of 65 will start accumulating fat in the abdomen, but also at the same time will lose muscle mass. For this reason, what we are having in the geriatric field is that we have a central obesity associated with sarcopenia. Sarcopenia means loss of lean mass. And so actually the big issue is that was lipohypertrophy somehow the phenotype of aging in HIV, and is there any difference between sarcopenic obesity that we see in older people to the sarcopenic obesity that we see in HIV-infected people? You have to remember the fact that at that time we collected data, but we were not so much aware about a sarcopenic problem that was affecting our HIV people, because presumably our people were too young to experience sarcopenia at that time. And so my issue is that more and more we go on, more and more our patients are getting older, we are aware that the phenotype of lipohypertrophy is getting closer to the sarcopenic obesity phenotype that we see in older individuals. Of course, lots of research need to be done, but regardless, this difference there may be difference in pathogenesis. I still believe that the treatment should be the same, because actually the principal rule is that people should not be overweight, and people should practice exercise. And so these are the two masterpieces so that to decide treatment, and we will try to address future studies regarding how to address, let us say, sarcopenic obesity as, let us say, the new phenotypic condition of people living with HIV.
Thank you very much, Giovanni, for your very detailed answer. May I ask you to quickly answer, please, the last question, so then we move on to the second speaker. Do you think is there any difference between people from resource-limited settings and people from high-income settings, people with HIV, of course, in the patterns of aging? I mean, there is an earlier onset of frailty among those coming from low resource-limited setting. Has this anything to do with the drugs used, or what else?
I do believe there's a difference. You need to understand that there are many factors that contribute to frailty. One of the most important factors is social vulnerability. And so if I think that, for instance, the situation of most new HIV-infected people diagnosed in my country, Italy, is made up of people coming from sub-Saharan Africa, and they may be first-generation migrants. Of course, this situation may put them at higher risk of social vulnerability, and this is definitely a risk factor for frailty. But also, there may be more complex reason for that, because we know that there may be some epigenetic differences, because just people moving from one country to another country, they change climate, they change diet, they change work. And so all this make them be exposed to risk without having, let us say, a common background, a common genetic background. And for instance, we know that even outside HIV migrants may even double or even more the risk of diabetes, of cardiovascular disease, just because they are moving from, for instance, sub-Saharan Africa to my country in Italy. And so actually this is why we need to concentrate on prevention strategies, especially in first-generation migrants with HIV, because they may have, let us say, competing risk factors that put them at higher risk of comorbidities and of frailty.
Thank you very much. Thank you very much, Giovanni. Very interesting presentation, and thank you also for your answers. Now the second speaker is Alan Winston from the St. Mary Hospital in London, where he's a clinical reader and consultant physician in HIV and genitourinary medicine. He has an MD in antiretroviral clinical pharmacology, and his research focuses on non-infectious comorbidities associated with HIV disease in the modern antiretroviral era, with a strong focus on central nervous system complications. He is also the principal clinical investigator on the POPPY study, a cohort study describing the incidence and nature of comorbidities in HIV, and leads the clinical work package of the COBRA consortium. So I kindly ask the moderator, Giulio, to mute all the line except Alan's line. And Alan, please, welcome to our webinar and go ahead with your presentation. Thank you. As soon as we can hear you, did Giulio unmute your line? Alan? Giulio, do you know what's going on? I guess we have a technical issue. I hope we are able to solve this issue in a few seconds. Giulio, can you hear me? Hello, Giulio?
Hi, it's Alan. Can you hear me?
Oh, yes, we can hear you, Alan. Okay.
You can hear me now?
Yes, we can hear you.
All right, okay, great. So good afternoon, everyone. It's a pleasure to be here. Could I have my first slide?
Okay, the slides are here. Go ahead, sorry.
Okay, thank you. So I'm Alan Winston from London. It's a pleasure to be here. If I can have my next slide. So as Giovanni has outlined, the age of the people living with HIV in Europe and the people that we're looking after in clinic is aging dramatically. This first slide is from Public Health England, so data from the UK. But if we look at any Western European country or North American country, we see similar data. The number of individuals living with HIV above the age of 50 was very low just a decade ago, but now it's roughly a third of the patient cohorts living with HIV and who we are looking after. We go to the next slide. Now, we hear a lot about aging and HIV. We heard in the last presentation about non-infectious comorbidities being more prevalent, and we hear things like this is due to inflammaging or antiretroviral toxicity, and we also hear that HIV may cause premature aging or accelerated aging or change the spectrum of aging. If we go to the next slide. What I'm going to do for the next 15 minutes is talk about some of the evidence that we have coming along, some studies which are looking at the effects of living with HIV and growing older, and some of the data that we're starting to see. So I'll talk about some studies within the European area, and I'll also talk a little bit about a specific comorbidity. I don't think we'll have time to get to the end of the presentation, but I know that the slides are available to everyone on this webinar. So if we go to the next slide, so one group of studies are the POPI and the HIV study. Now, the POPI study stands for Pharmacokinetics and Clinical Observations in People over 50, and this is a study that's been conducted in the UK and Ireland, and it's looking at a detailed medical assessment, medical history, lifestyle factors, and the presence of medical problems in people older and younger living with HIV. And what's very important about the POPI study is it's recruiting a comparative control population. So it's recruiting people who are over the age of 50 who are not living with HIV to compare what's going on in people who are living with HIV. And the negative population are being recruited from sexual health clinics and from with the help of community groups. So we have a population that's as well matched to the HIV positive population as we can possibly have. Now, Giovanni has already mentioned that in the Netherlands there is the HIV cohort study, which is very similar to the POPI study. And I won't talk about this today, but we have a sub-study between the two studies called COBRA, looking specifically at neurological conditions and cognitive function in older people living with HIV. If we go to the next slide, please. Now, the overarching aim of our study in the UK and Ireland is to examine within a study setting the effects of ageing on clinical outcomes of people living with HIV, and to look at the instance and outcomes of specific comorbidities, and to hope that in the future this can help us to develop evidence-based recommendations for what we should be focusing our resources and our monitoring on, and also to look at the impact of antiretroviral therapy and the different types of antiretroviral therapy. If we go to the next slide. Now, the three groups we have in the POPI study are people living with HIV above the age of 50, and these are individuals who are white or black African ethnicity and acquired HIV sexually. And we've limited the POPI study to these groups, as these are the largest groups living with HIV in the UK and Ireland. We also have a younger HIV positive group, and as I mentioned previously, what is key to these studies are comparative control group, so HIV negative individuals above the age of 50. If we go to the next slide. Now, in the POPI study, there's a detailed assessment which happens every year. It's a longitudinal study currently funded for 3 years. And the individuals entering the study really go through a very extensive medical and social history review. And the study visit takes a whole morning or a whole afternoon. And this is because we really want to look into detail into what's going on, the lifestyle factors, the medication use, and a detailed history of older and younger people living with HIV in this matched control group. So we look at patients, individuals' demographics, medical history, current antiretroviral use, other medication, a detailed family history, a social history, lifestyle factors. And if we go to the next slide, we also measure anthropometrics, which is height and weight, and study questionnaires. For the female participants, there's a detailed reproductive history. Everyone has a cognitive assessment, and an assessment of bone health using DEXA scans, and falls and fracture risk and frailty assessment, and blood samples are stored. If we go to the next slide. Now, the study has fully recruited as of the end of 2015, and we'll have the final baseline results presented this year. But at the time we were able to undertake a preliminary analysis, 540 people had been recruited into the POPI study. And if we look at these 540 people, there was roughly 300 living with HIV above 50, just over 100 living with HIV below 50, and approximately 100 matched controls above 50. And I won't go through everything in this slide, but you can see what's important was that we were able to recruit individuals not just of white ethnicity, but those of black African ethnicity, which are always underrepresented in studies. And if you look at the age range at the bottom, we're able to recruit individuals both living with HIV and HIV negative controls from the age of 50 right through to the age of 80. If we go to the next slide, please. Initially, just looking at weight and BMI, there's not marked differences between those living with HIV in the negative group, and looking at blood pressure, it's slightly higher in the two older groups, and we see the grip strength is slightly lower in the two older groups. If we go to the next slide. Now, this is where things become interesting. If we look at smoking status, we can see that current smoking status is similar in older people living with HIV in the matched control group, so just over 20%, and it's slightly higher in the younger people living with HIV group. If we look at alcohol consumption, we can see that this is slightly lower in both groups living with HIV compared to a control group. And this has been reported in other studies, and we wonder if people living with HIV worry about alcohol consumption in their liver. But if we go to the bottom of this slide, we can see that recreational drug use is markedly higher in people living with HIV compared to the negative control group. Now, this is of key importance, because when we're going to start looking at frailty, at the presence of comorbidities, at what's happening to people living with HIV in different age groups, these lifestyle factors are going to play a very important role. And the fact that we're seeing much higher rates of recreational drug use could be driving a lot of things that we're seeing when it comes to comorbidities. If we go to the next slide, if we look at non-antiretroviral medication use, and the blue group are the older people living with HIV, you can see this is much higher in people living with HIV. We don't at this time have a breakdown on what this non-antiretroviral medication use comprises of. So is it blood pressure medication or cholesterol medication? And if we go to the next slide, if we look at healthcare utilisation, we can see that most people attend their GPs over the last 12 months, and 15 to 20% have attended A&E. But if you look at attending another hospital specialist, this is higher in the older people living with HIV. And importantly, attending a psychiatrist was a lot higher, 28% versus 13 and 12% in the other groups, for the older people living with HIV, as was having undergone a hospital procedure. If we go to the next slide. Now, the POPPY study is still a relatively small study to actually look at hard-end organ events. And there's other studies around the world looking at cardiovascular disease, such as the DAD study. So we weren't really trying to replicate this. We weren't expecting to see a big signal here. But even in this preliminary analysis, we see that cardiovascular events, so MI, angina, narrow blood vessels, this is a higher rate in the older people living with HIV compared to the younger group or the negative control group. And there's a trend towards differences in nervous system events, and also a higher rate of chest diseases, respiratory diseases such as asthma and bronchitis. If we go to the next slide. We also look at bone health in the different age groups of people living with HIV and the control population. We can see that there are differences in the older people living with HIV in blue, where we have the lightest group, the bone mineral density of the normal range. The slightly darker is reduced bone mineral density, and the darkest is the bone mineral density that's reduced that would normally be classified as osteoporosis. But what you can see is that first shaded group appears to be higher in the older people living with HIV. If we go to the next slide. So our initial conclusions from this analysis was that comorbidities do differ in younger and older people living with HIV compared to the best match control population that we can recruit at this time. And healthcare utilisation did also differ. But importantly, and what is key, is that lifestyle factors also differ. And what we really need to do is try to start teasing out what's causing what. How much of these differences are truly related to HIV or truly related to antiretroviral therapy, and how much are related to other lifestyle factors. And we need to remember that these are preliminary results, and as I mentioned before, we'll have a lot more results later in the year. If we go to the next slide. Now, our collaborators in the Netherlands are a good few years ahead of us, and Giovanni showed this slide, a very similar slide from his data set. But other groups have shown this similar signal. This is from HIV, looking at comorbidities, so other medical problems in people living with HIV, and describing, again, as we've seen in Poppy, higher rates in those living with HIV compared to a negative control population. And the next slide, again, HIV has reported similar DEXA scan results, and this is slightly different from our results, as this is corrected for all other baseline factors. But when they do correct for this, they still see these higher rates. Now, I think what I'll actually do is, if we go to my next slide, I was going to talk about a specific comorbidity, but I'll stop there and take some questions. But as I said, these slides are available to everyone on the call.
Thank you very much for this, and I was just going to tell you, you have 2 more minutes, and I'm very happy to use these 2 minutes for asking some questions.
Okay, so if we've got a couple of minutes, could we go to, can you flick through to slide 32, which is at the very end? So what I'll just talk about is the future and where we are. So our current guidelines, here we are. So our current guidelines, sorry, the last slide, the EATG guidelines. So our current guidelines, we've flicked too many, so I'll just speak while we get to this slide. Our current guidelines are not based on hard evidence, but are based on the fact that we are observing higher rates of comorbidities in people living with HIV. And what's important, as Giovanni very nicely described, was that we need to be watching for these comorbidities and screening for them and managing them. If we go to the next slide, there are some studies now, specific studies looking in people living with HIV at management of comorbidities or preventing comorbidities. So the REPRIEVE study in the United States, is a large-scale study looking at cardiovascular prevention and randomizing people living with HIV to a statin or not a statin in individuals that wouldn't otherwise be treated with a statin, so a cholesterol-lowering drug. And if we go to my last slide, which is the next one, what is the future likely to look like? So are we sitting on a time bomb, or could things actually get better? And I don't think we're necessarily sitting in a time bomb, but what this slide outlines are how some risk factors for the presence of comorbidities are likely to increase, but some other risk factors may actually reduce. So if we think about some risk factors which are going to reduce in the future, we're treating HIV earlier and we've got better, much more tolerable medication. So a shorter duration of untreated HIV and less individuals exposed to drugs from years ago that were toxic could lead to a reduction in comorbidities. But on the other hand, there's other risk factors which suggest we could see an increasing risk of comorbidities, which is a longer duration of antiretroviral therapy, newer drugs that we don't know everything about, and also aging and lifestyle factors, especially recreational drug use. So I will stop there, and I look forward to everyone's questions.
Yes, thank you, Alan. I think we can move on with the last presentation, so we can probably have a 5 minutes discussion at the end of it. So sorry for those who are asking some questions now. I hope we can ask them at the end of the presentation, of the last presentation, which is the presentation from Mario Cascio from Italy. Mario is an activist, a member. He has been living with HIV for over 30 years now. He's a community member, an activist. His activities are focused mainly in prison settings through counseling and peer education, and he is currently part of the policy working group at the EATG. So Mario, please go ahead.
Okay, thank you, Giulio. Hello, everybody. My name is Mario Cascio, and today I'll be talking to you about what it's like living and aging with HIV from a community perspective and from my personal experience. I'm a 62-year-old Italian, married with 2 children, who has been living with HIV for over 30 years now. I'm also co-infected with hepatitis B and C. When I first got my diagnosis more than 30 years ago, I wasn't very much surprised about it, since I had been a drug user. But it was indeed a turning point in my life. Not much was known about the disease in 1985. The only thing people knew was that it could be passed on and that death was right around the corner. People were scared, terribly scared of catching it, and I was scared. We were all scared of dying from it. No future. These are the words that depict our lives. Of course, this is history. We all know how things have changed since then, but I wanted to start my story with these words because many of the things we experience today have a sort of memory of the past, closely linked and connected to those initial years, to those initial fears, even in people who haven't personally experienced that period. Next slide, please. What's it like to live with HIV, and what's it like to age with HIV? Well, I've often asked myself these questions. In the early years, it meant living with a Damocles sword over your head. You never knew when your time would come. In the ARV era, things have changed. It took me quite a while to get used to the fact that I could have a future, that I could plan a quite normal life. But something kept on being underlined, an undefinable, irrational fear, similar to that of the early days, which would just pop up once in a while. At the end, I've decided that these irrational feelings were just part of my life. Discriminations. I must say that in these 30 years, I have not experienced great discriminations, unlike many other people living with HIV. Well, maybe at work, those knowing of my status would just look at me thinking, oh, poor him, which of course I hated, but nothing more. In my personal relationships, I have never experienced refusal, and the same in my sexual life. After my first wife died from AIDS, I married an HIV-negative woman who accepted my situation right from the start. It may seem strange and illogic, but my worst experiences of discrimination came from healthcare professionals. For example, at the dentist, who would refuse to visit me saying he didn't have the adequate equipment if I said I had HIV, but would accept me if I had hepatitis C. Or when keying for gastroscopia and placed at the end of the list when I should have been among the first. Or when a surgeon would refuse to carry out a minor surgery for the removal of a sore lump. Those things do hurt you. You think, doctors should know better than others how HIV is transmitted. But discrimination doesn't come only from others. One day, I realized what the word self-stigma meant. In the city where I live in Sicily, it's common to go with a friend to a cafe and share a coffee. For the work I was doing, I would do this many times during the day, moving from one working place to another. Without realizing it myself, I used to always ask my colleague to drink from the cup first. Then I would have some myself. One day I did the same with a friend who knew about my status. Well, when I told him to drink first, he looked at me and said, "No, it's you that must drink first." Suddenly I realized that often it was me that was discriminating myself and not the others. I think this has to do with the words that may circulate unconsciously in the minds of many people living with HIV. I probably deserve it due to my socially unacceptable behavior, and I may indeed be dangerous to others. A sense of guilt that has accompanied me for a long time and that maybe still pops up once in a while. Next slide, please. So it's been a long journey, that of self-acceptance. Along this journey, it has been important for me meeting people with my same problems. At the beginning, it was difficult because most of my friends had died from the disease, and I had hardly anyone to talk to. But then, through the Internet, I was able to contact people and organizations, which have been of great help to me. In the 90s, Internet was an extremely helpful tool. There was a great need to share feelings and fears at the time. I remember how surprised we were in a group I had joined that we had reached the year 2000, a great sense of solidarity. We would lick our wounds together. I have always realized the importance of peer support, which worked for me, and since then I have always done the same for others in need of help, personally and later on as an activist. Even disclosing my status has been part of this journey, and often has to do with this sense of underlying guilt. I have become visible only in recent years. My 2 children are now grown up, and I don't fear any discrimination for them any longer. But I did when they were still in school age. But the most difficult moment in my life with HIV is when I first disclosed my status to my elder son, and afterwards when I disclosed to my younger one. I remember rehearsing for months before actually being able to openly talk to them. But in the end, it was relieving. It was the beginning of a new relationship, without secrets and pills hidden away or taken when not seen from them. Another important part of my life with HIV was when I married this HIV-negative woman, and together we decided to have a child. We had read in the papers about the washing of the sperm, and that something that seemed impossible was actually possible. This was my great victory over HIV. I transformed all the negativity connected to my status in something that was extremely vibrant, generative, full of joy. My doctors at the HIV clinic would discourage my wife from marrying me. They would say, you're going to soon be a widow. Or even from having a child with me. The child will soon be an orphan. My wife would look at them and ask them, I don't understand how you can pretend doing the work you do. How can you ask my husband to believe in a future when you're the first not to believe in it? Well, that kind of attitude would have prevented me from doing some of the most joyful things in my life if I had not been so stubborn and hard-fighting. Next slide, please. Taking care of your health when you're living with HIV isn't always easy to do. Personally, I had to learn it the hard way. I could say I was a well-informed patient, always hungry for information on HIV, but that was not totally true. I was missing some very important information on disease progression and on antiretrovirals, which in my specific case led me to interruption of therapy. This happened 9 years ago. I seriously fell ill from some serious infections which almost cost me my life. I blamed my doctors for that they hadn't explained things well enough to me. But I know that it was mostly my fault. Something had not worked in my patient-doctor relationship. Since then, I've tried to change things, negotiating the right decisions at the right moment with my doctor, which is not always an easy job to do. And this takes me to another question I often ask myself. Today, I'm faced with the fact that I'm getting older, and things seem to get more complicated as regards my health. In the 80s, our doctor's mission was to keep us alive as long as possible, or that of accompanying us in the less painful way possible towards death. In the ARV era, emergency was over, and my doctors were doing a more routine work, which consisted mostly in prescribing the right therapy and regularly checking my blood tests. But that was it. But as I said, my healthcare needs are changing. Small aches and pains and health problems that are difficult to understand if related to therapy, to age, to HIV, or to the three put together. Today, I don't want to simply survive. I want an acceptable quality of life, and to achieve that, I need an acceptable level of health care. What I don't need today is a doctor who merely checks my routine blood tests. Next slide, please. Well, me, like many others my age, need a more holistic approach from our doctors and a greater collaboration in deciding strategies and therapies. For example, this is what happened to me lately. It was a couple of years that I had been experiencing various symptoms. My knees were hurting when going up and down the stairs. Constant intestinal problems. I was losing weight. Well, my doc did prescribe some examinations to exclude some serious problems, but then just said, well, your knees probably depend on your age, the intestinal problems on stress, and your weight on your diet. I said, okay, but I suggested a switch in therapy. I felt something was going wrong with that. In the end, we agreed on a switch, and you know what? After 1 week, I no longer had any problems with my knees. After 4 months, my intestinal problems had disappeared, and after 8 months, I had gained more than 4 kilos. What do I mean by this? I mean that we need a shift in healthcare centered on the needs of us patients. Doctors can no longer do a good job without the help of us patients, and this is particularly true when you get older. Next slide, please. My major challenge today is, what can the healthcare system do, and what can I do to keep myself in good health at the moment in which I am approaching the older age? My quality of life will depend on this. What can I do as an informed patient? But what must the healthcare system do to meet my ever-changing and ever-growing needs? Next slide. For example, I'm co-infected with hepatitis C. New drugs are on the market which can eradicate it. But I do have some liver fibrosis, but not enough to get access to these new drugs. My general health will certainly be negatively influenced by this fact. It's just like as if one day they find a cure for HIV, but they tell me that I cannot access this cure because it's too expensive and I'm not sick enough after all I've gone through. I understand that innovative drugs are certainly expensive, but pricing is out of control and many national health systems are collapsing. But from a patient's point of view, this is just not understandable. Next slide. And what about other comorbidities, heart disease, kidney function, hypertension, diabetes, loss of memory, just to mention a few? I know that these are emerging health issues for older people living with HIV, but what should I do as a patient, and what should my doctor do in order to adequately take care of my health? What should I expect for my future years with HIV? With the burden of other needed medications, would interactions with my therapy be a problem? These are just a few of the questions I ask myself today. Next slide. And what does undetectable mean to me? This is an important question. It took me time to realize the importance of getting undetectable. Of course, it is extremely important for my health, keeping the virus under control, but it has become even more important for the sense of guilt and self-stigma I was talking about before. Being virtually non-infectious to others has alleviated the burden of underlying anxiety. I'm still careful, but just not in the same way. If I forget to put my razor blade away or if I cut myself, I'm just not that anxious about it. I'm more comfortable in my sexual life, and on the whole, I feel more normal. It has allowed me to reach a physical and emotional well-being at the same time. And since I believe that one cannot be reached without the other, grasping the importance of being undetectable is an important step towards reaching this equilibrium. But as I said before, today reaching undetectability is not my ultimate goal. Today we must go beyond undetectability towards a better quality of life. Next slide.
I'm sorry, Mario, can you hear me?
Yeah?
I'm sorry, the time is over. Can you continue your conclusion?
1 more minute.
Just 1 minute, please.
Yeah.
Okay.
Okay. Sometimes you even feel guilty about complaining about your health. People would think, what the hell, you're still alive, unlike so many others. What's there to complain about? Of course, these are the doctors and people who saw so many people dying every day for so many years. And many people who have lived with the virus for more than 10, 15 years, most of which are over 50 today, have had to pay a heavy toll to their survival. Many, for example, have experienced body changes due to the toxicities of the early drugs, a humiliation of their bodies with the shame entailed in that. The so-called long-term survivors, people who have been living with the virus for over 20, 30 years, may not be a special category, but they do have certain specificities. They've gone through a significant psychological trauma, which still today has not been sufficiently investigated. Researchers say that a high percentage of people living with HIV experience depression and strong levels of anxiety, which is understandable for a disease which is serious, life-threatening, and which is surrounded by so much stigma and discrimination. And this is particularly true for people aged 50 or over that have been infected over 20 years ago. Watching all your loved ones, family and friends, pass away and disappear from one day to another is indeed a trauma. You have to become emotionally insensitive and numb in order to cope with suffering. But what are the psychological consequences caused by such trauma? And what is their impact on the well-being of a person? This population often bears the physical consequences of long-term therapies of first generation. Changes in body fat were common, and shame and problems of self-acceptance were certainly accentuated. This was particularly true for women. We are the first generation of people aging with HIV, and therefore continue being the guinea pigs of the situation. Like in the past, when we would be experimenting the various drugs made available, today we are the first generation experiencing the long-term consequences of antiretrovirals and their interplay with HIV and aging.
Mario, sorry. We have to close our webinar now. I'm very sorry.
At least.
Sorry?
Well, in conclusion, I've gone through many experiences in my life with HIV, some extremely sad and some painful, many ups and downs, and today, me, like so many others, are now facing this new challenge for the unexplored territory of aging with HIV. Okay, thank you.
Thank you very much, Mario. I'm so sorry, but the time has run. So I'm afraid we cannot have any question now because we are already out of time. But if you want to send an email with your question, we can try and get some answer. You can also email my personal address, email address at giuliomariacorbelli@gmail.com. I'm sorry for not being able to ask questions, and thank you very much for joining this webinar. Please stay tuned for the next webinar. It will be in 1 month or so on our website, agingwithhiv.com, and on our Facebook page, Aging with HIV. Thank you very much.